Good afternoon, everyone. Welcome to Grand Rounds. Dr. Bhamidimarri received his medical degree from Andhra Medical College in India and completed his residency in internal medicine at Bronx Lebanon Medical Center, where he also served as chief resident. He went on to complete fellowships in gastroenterology and transplant hepatology at Mount Sinai in New York. He's been with us at the University of Miami since 2011 and currently serves as the chief of hepatology. He has published multiple book chapters and articles on hepatology and transplant hepatology and has been an invited speaker at several international and national conferences. He is a peer reviewer for BMC Gastroenterology and Medicine and is an editorial board member for the Journal of Advanced Gastroenterology and Hepatology. Please join me in welcoming Dr. Bhamidimarri as he gives his talk titled EndoHepatology and Beyond. Is this within our scope?
Hello, everyone. Good afternoon. Thank you for this opportunity to speak in the Grand Rounds today, and thank you, Dr. Forney, for the introduction. So as my title implies, Endohepatology and Beyond, I'm going to talk about the applications that we can do with our endoscope for managing patients with liver disease. So these are my objectives in the next 25 minutes or so. I'm going to talk about endohepatology, which is basically EUS-based liver applications. It's an emerging field, and if you have searched for endohepatology on PubMed, you're going to see 13 results as of today. But again, as I said, this is an emerging field with several diagnostics and therapeutics that we can apply for managing our patients with liver disease. I'm going to talk about endoscopic, bariatric, and metabolic therapies that we're also offering our patients at our Division of Digestive Health and Liver Diseases. And I'm going to briefly close with new frontiers in liver biopsy. So we're just coming off of the COVID-19 pandemic, and we've been quite resilient. But if we see our clinics, we're now hit with a new silent pandemic since the last decade. This is a world map showing several countries that are in the dark orange and red that show that fatty liver and obesity is the silent pandemic that is brewing. And these countries, which are represented in the dark colors, have approximately more than 20% of their population with fatty liver disease. Obesity rates in the US are also growing, and you can see in this map from 1990 up to the projected map for 2030. We're currently in 2020, and our obesity rate is close to 42%, and we're going to be over 50% by the next decade. And the result is there's also increasing rates of fatty liver in our population. Globally, a quarter of the adults have already fatty liver, and in the Western world especially, that rate approaches close to 46%. Now, among patients with fatty liver, NASH, which stands for non-alcoholic steatohepatitis, this is a progressive form of the fatty liver where there is inflammation and fibrosis, and that accounts approximately 6.5% of the population with fatty liver. And approximately 70% of the patients who have fatty liver also have type 2 diabetes mellitus. Another baffling number that we're going to see as we see patients with fatty liver is the presence of fatty liver in non-obese adults. So this is termed as lean NAFLD, and that rate currently is approximately 7%, which is also projected to go up in the near future. Now, the corollary to that is we're also seeing increased transplant rates, especially liver transplant rates for the conditions related to alcohol, HCC, and fatty liver. Now, the SRTR uses the term other or unknown to basically term it under the umbrella of NAFLD, but since NAFLD is a non-diagnostic terminology, and again, usually a diagnostic of exclusion, there is now a push to call this condition MAFLD, which is metabolic dysfunction associated fatty liver disease. And that basically includes all conditions under the term of fatty liver, irrespective of steatohepatitis or fibrosis. Now, in hepatology, we know that fibrosis, among all the characteristics of fatty liver, is one of the determinants that correlates with the risk of increased liver morbidity and mortality. And that morbidity kind of takes off exponentially once the fibrosis hits more than stage 2. Again, you can see that in stage 3 and stage 4, liver-related morbidity and mortality is exponentially high compared to F0 and F1. So traditionally, liver biopsy was one of the ways how a fibrosis could be assessed. But since the last decade, we have several non-invasive tests. We currently use a lot of wet biomarkers. These are blood-based tests like APRI, which stands for AST and platelet ratio, FIB4, the NAFLD fibrosis score, ELF test, and fiber test. These are also commercially available, or these are online calculators, which you can use to put in the patient's labs and demographics to get a number. And with that number, we can actually determine the amount of fibrosis in a patient. We can also use dry biomarkers. These are imaging-based elastography technologies. And although a lot of these dry biomarkers are non-invasive, they have several limitations. Like, for example, with elastography, narrow intercostal spaces, especially among women, increased pannus or subcutaneous fat, interlobar variability, inter-observer variability, who is doing the FibroScans, all of this can cause some problems with accuracy with the elastography. So a new modality in the diagnostics is an EUS-based shear wave elastography. So this is the use of an EUS endoscope, and an additional processor like a 2D beam mode imaging is attached to the EUS scope. We can measure elastography in both right and left lobes. There is less variability because the liver is closer to the stomach, and we can actually get a shear wave elastography using an EUS scope. And the other advantage is any gastroenterologist or hepatologist can do it while doing a routine endoscopy. The other EUS-guided applications and EUS-guided liver biopsy. Again, I was showing you the proximity of the liver to the stomach and to the duodenum. Previously, FNA needles were used to get a biopsy, but now the techniques have gotten better. We're using 19-gauge FN biopsy needles. And there are also some advances in the tip of the needle to get better tissue sampling. The advantages of this over the percutaneous biopsy is it's a real-time ultrasound. You can also do a real-time Doppler to avoid the vessels. You can get multiple passes with a single puncture. You have the ability to actually sample both lobes of the liver. You can do a simultaneous EGD and the other interventions that I'm going to discuss in the next few slides as a one-stop shop for a lot of the diagnostics. And the recovery is quite rapid, and there's no intercostal soreness. The turnover time during the endo lab or the GI suite is much faster, and it's associated with lower adverse events. So overall, if you look at the cost analysis that are being published, EUS-guided liver biopsy appears to fare better compared to percutaneous liver biopsies. Now, another characteristic that all hepatologists like to know is the portal pressure, as not just fibrosis, but portal pressure also correlates with several clinical events. So normal HVPG or portal pressure is less than 5 mm, but you can start seeing some disease morbidity once the HVPG goes up. And once the HVPG is more than 10, you can see the development of ascites, the development of esophageal varicose bleeding, the risk of HCC and decompensation, and risk of recurrent bleed, higher mortality, and failure to control bleeding occurs at much higher HVPG. Traditionally, an HVPG is measured by the interventional radiologist when they pass a catheter through one of the neck veins and the catheter wedges in the hepatic vein, and a manometer kind of uses an indirect measure of HVPG, which is a subtracted pressure from the wedge pressure and free hepatic vein pressure. Now, one of the disadvantages of this is it's good for sinusoidal hypertension and post-sinusoidal hypertension, but it's inaccurate in pre-sinusoidal hypertension. Now, an EUS can also be used to measure the portal pressure gradient. The advantages are there is no need for contrast, there's no need for radiation, And portal vein can be directly punctured with a 25 gauge needle and a manometer is attached. And because we can actually sample pressures from the portal vein itself, it's even accurate in pre-sinusoidal hypertension. It is safe and it has shown that there are no serious side effects. Technical success is almost 100% with this modality. And you can also do a simultaneous EGD and EUS guided liver biopsy during the portal pressure measurement. Now, moving on to EUS-based therapeutics, gastric varices are some of the challenging aspects to manage in a patient with decompensated cirrhosis. Gastric varices can be present in up to a third of patients who have cirrhosis, and a quarter of them bleed within 2 years of diagnosis. Approximately 16% will rebleed within a year's time. But when you actually look at the gastric varices with an endoscope, sometimes they can mimic thick gastric folds. And the other important caveat is gastric varices can bleed at even low portal pressures, as opposed to esophageal varices that bleed typically when the portal pressure is more than 12 millimeters. Treatment, again, banding is very inefficient for treatment of fundal varices. So we generally resort to IR methodology like the TIPS or BRTO as shown in this slide, where the interventional radiologist goes to the vessels and injects glue or coils to prevent these gastric varices from bleeding. The advantage of EUS is it can actually differentiate thick gastric folds from the varices. And now, when you look at how we can obliterate these varices, this is an endoscopic view on the first figure of the gastric varices. This is an EUS view. You can actually see the Doppler, which shows the feeder vessel for these gastric varices. And one can actually inject cyanoacrylate, which is a glue, or coils into the varices. And post insertion of these coils, you can see how well these varices get deflated, and you can all do this in a single endoscopic procedure. As you see in this slide, alcohol and fatty liver, which are the most common causes for liver transplant indication in the current days, these are the patients that were looked at, and combo treatment with coils and cyanoacrylate appears to have lower risk of rebleeding, lower risk of varices reappearance, and lower reintervention-free time. Now, the determinants of rebleeding is really the size of the gastric varice, the degree of liver dysfunction, typically MEL over 18, and in which setting it's done. There is some variability based on the operator, but now there has been increasing literature that compared to cyanoacrylate or coils alone, combination has better technical success, better clinical success, and lower rates of rebleeding and reintervention. Now, if a reintervention needs to be done, a combo treatment is still better compared to coils or cyanoacrylate alone. And again, the advantage of the combo treatment is there is less risk of pulmonary embolism due to the cyanoacrylate embolizing into proximal vessels if you also use coils. So if we can use this as one of the modalities, TIPS can be reserved as a salvage for patients who have higher MELs and who have very decompensated liver disease. Now, talking about TIPS, there is also this investigational study that is currently in animal models, but appears to be promising. This is the placement of a portosystemic shunt using the EUS-based technology. Now, we also use endoscope, typically the EUS and the ERCPs, for accessing the bile ducts. Now, we know that ERCPs can be unsuccessful due to challenging technologies, and decompensated cirrhosis especially makes the patient not a good surgical candidate. So alternatives in patients who need biliary interventions are typically interventional radiology interventions like PTC or cholecystostomy. And the disadvantage of these procedures is there is discomfort, there is external drain, and there's also risk of infection, which makes these choices a bit unfavorable. But with the use of an EUS, depending on where and in what setting is it benign or malignant strictures, we can basically use rendezvous techniques where we can pass a guide wire through the duodenum or through the stomach, or we can even stent the bile duct either at the level of the stomach or at the level of the duodenum. Now, in patients who have cholecystitis and they're too sick to undergo cholecystectomy, an EUS-guided biliary drainage is also feasible. And as you can see in this figure, a lumen-opposing stent can be used to drain the gallbladder. Now, going into neoplasms, ablation techniques can also be used using an endoscope. Typically, the ablations would destroy the neoplastic tissue by ischemia or necrosis. And again, you can use chemical or thermal ablation. There are RFA-based technologies where it's a probe which provides local tumor control, and it ablates even the tumor ingrowth within the stent, thus maintaining stent patency. It's easier, it's cost-effective, and there's another modality which is called PDT laser, where an ERCP with spyglass is used to basically treat the bile duct tumors. So you use a photosensitizer 48 hours before the procedure, and the laser basically activates the product, and you also use stenting to prevent biliary infection. You can see in this diagram in the bottom how the PDT actually has helped in controlling a local tumor within the bile duct. Moving on to interventions for obesity, here you can see the graph. Now, everyone who has obesity and fatty liver disease or metabolic syndrome, now lifestyle interventions, diet, and physical activity are some of the main pillars for treatment. But you can see that the least invasive methods are also least effective. And the most invasive methods, like the bariatric surgery, is most effective. However, it is associated with a lot of complications. And less than 2% of the population are actually eligible because of their surgical eligibility or insurance issues or due to comorbidities. So EBMT, this is endoscopic bariatric and metabolic therapies, have come in, and they can potentially fill the therapeutic gap that we have between the medications and the surgery. Typically, these ABMTs would achieve 25% of excess weight loss at around 1 month. They're relatively safe with side effects of less than 5%. And they can be classified into gastric EBMTs, where the primary outcome is weight loss and secondary outcome is their effects on metabolic issues. Whereas the small bowel EBMT, the primary modality is effect on metabolic aspects, and the secondary outcome is on weight loss. So this is a slide that I adapted from Dr. Popov, and you can see that these EBTs can be divided into therapies that are already in practice or FDA approved, which includes balloons, endoscopic remodeling or gastroplasty, aspiration therapy, and transpyloric shuttle. And although this is approved, it's not yet available in the US. And then there are the small bowel modalities like the duodenal sleeve and DMR, which are up and coming in the near future. So instead of going over each and every one of them, I kind of used this table to show the efficacy of the EBMTs with pooled data. So you can see that intragastric balloons or ESG aspiration therapies and duodenal sleeve, they have pretty good rates of more than 10% weight loss at the end of 1 year. There's also metabolic and NAFLD parameters that improve. And although there are side effects with each of them, if you look at the side effect, the serious side effect profile, it's less than 5%. An aspiration therapy where removal of 30% of ingested calories happens via a PEG, there is durable weight loss up to 4 years in patients who have discontinued even before. And there have been some critics who basically think that the aspiration could be like an assisted bulimia. However, eating disorders have not worsened in patients who have undergone these therapies. The advantage of some of these approved therapies is in high-risk BMI patients, they can actually be a bridge prior to their orthopedic surgery or cardiovascular surgery, where they can lose the weight prior to the surgery. And there's also some interesting data that's coming up where transplant surgery, which was supposed to be contraindicated due to the severe BMI, patients can actually lose weight with some of these level 1 or less complex procedures and can have better outcomes because of the EBMT. So I'm going to talk the next few slides on duodenal mucosal resurfacing, which is one of the clinical trials we are about to do in our division of digestive health and liver diseases. Now, duodenal exclusion or delay is the primary mechanism that is kind of like in gastric bypass or duodenal sleeve, where in DMR, we're going to ablate 6 to 9 centimeters of post-ampullary duodenal epithelium. So we're going to lift the submucosa in the duodenum, and we can RFA the superficial layer. So what it basically does is all the villi or the surface lining of the epithelium gets resurfaced. And it's basically using the mechanism called the incretin effect, which basically PO glucose is a strong amplifier of insulin secretion compared to IV glucose. So we're going to use some of these gut endocrinology issues and help the patients lose weight and help in their metabolic dysfunction. There's also another hypothesis where the L cells that produce the GLP in the small bowel, we're going to ablate all these L cells, and when these L cells actually recover, they're going to have a better function with the GLP production, and that can keep the metabolic effects in control. So again, there are several gut hormones which are targeted mainly by the small bowel EBMTs that include glucose-dependent insulinotropic polypeptide or GIP and the GLP-1. And again, most of these hormones affect not only just satiety, but also motility, which basically delays the duodenal emptying and helps in the better control of metabolic effects. So there are two big trials, the REVITA-1 and the REVITA-2 that have been published. I'm going to talk about the REVITA-2, which is a more recent study. This is a randomized double-blind sham control study. It has been done in 11 centers across EU and Brazil. Now, 108 patients have been enrolled in the DMR and sham, those that have poorly controlled type 2 diabetes. Now, these patients are unselected for fatty liver, but 85% of the patients enrolled have fatty liver disease. This is based on MRI-PDFF. This study did not include liver biopsies, but MRI-PDFF or non-invasive testing was used. And if you look at the results at 6 months, weight loss, A1C changes, MRI-PDFF changes, and liver biochemistries all show greater improvement in the DMR group compared to the sham group. Side effects are more or less similar to the sham group. And the conclusions of this study, as you can see in the REVITA-1, which is the graph on the right, is patients were able to get the PDFF or the liver fat score up to a healthy patient, which is less than 5% in a large majority of the individuals. In the REVITA-2, again, you can see that DMR performs much better in the European population. And this is one of the studies we are very excited to start very soon in our division. The future plan is DMR plus GLP-1 RA. Now, both of them could work synergistically, and the hypothesis is we can eliminate the need for insulin in the patients who have diabetes that are dependent on insulin. So this is a summary slide of EBMTs on NAFLD. A lot of the heterogeneous studies are performed, very few randomized control studies. They have small sample sizes and variable results, so they're not adequately powered. There are some short-term studies which are negative, but remember that liver fibrosis takes time, and it also needs more than 10% of the weight loss. Bariatric surgery, although it has overall good outcomes, we need to keep in mind that the surgery is irreversible and there's increased rates of completed suicide and attempts, which is due to the pre-existing mental health issues, drugs, and alcohol. And therefore, for personalized medicine, we need to keep all the options available and discuss the candidacy for each of these therapies. Insurance coverage appears to be the biggest barrier. So if you look at this practical algorithm that I made for a patient who is obese and who has fatty liver disease, the first step is any fibrosis assessment with the non-invasive test, and you grade them into low risk, high risk, or decompensated cirrhosis. Now for disease monitoring, you can use either the conventional techniques or EndoHep is coming to be an additional tool. Even for decompensated cirrhosis, diagnostics can be done with PPG and liver biopsy compared to the transjugular way of assessing HVPG. For managing complications, low-risk patients typically won't have that many complications, but the high-risk patients, we can do one-stop shop with an EGD, and we can control the varices. We can also do several other things that I've discussed before. Now, when it comes to therapy, lifestyle interventions plus or minus medications are the mainstay to treat these individuals. In low-risk patients who prefer non-invasive methods, clinical trials are the best way. But in a patient who is ineligible for surgery or desires no surgery, we need to think about, does the patient need weight loss? And if it's weight loss, we basically advise them to get a gastric EBMT. If metabolic parameters need to be addressed, small bowel EBMT would be appropriate. And again, if a patient is certainly worsening and prefers a bariatric surgery, certainly that is one of the tools that we need to keep in mind. For decompensated patients, again, medications appear to be the only option along with lifestyle interventions, but EBMT trials, like I said, prior to the liver transplant in the previous slide, especially in select cases, appears to be promising. So the summary, you can see that EndoHep is an additional tool to our intervention radiology colleagues. As we're going to see more and more patients with fatty liver, we need to work together with our IR team, and this gives us more resources. EBMT appears to be today's science and tomorrow's treatment. And now going into a little bit about frontiers in liver biopsy. In pure NAFLD or steatosis, there are no proteases, but in patients who have steatohepatitis and fibrosis, proteases like the CTSL are quite common. So the Glimpse Biotech developed some biosensors, which basically looked at 20 out of the 600 proteases. So once we get a blood sample from a patient, we add the biosensors to the blood tube. And when you look at patients who have NASH versus healthy, the area under the curve to predict NASH is really 0.97, which appears to be very promising. And this was quite independent of the sex, obesity, and type 2 diabetes. So again, very interesting trial, which we are going to perform at our division. And this liquid liver biopsy or a simple blood test could be a future liquid liver biopsy. And this can also be used for prognosticating the risk of cirrhosis and a great monitoring tool.
Dr. Bhamidimarri, is this your last slide? Because we have a minute left.
Yeah.
Okay.
So I want to basically talk a little bit about AI and machine learning. And here again, you'll see that the liver biopsy, once you apply machine learning to it, we can basically use computational and objective findings to the liver biopsy, which is more accurate and reproducible, and it's a great monitoring tool. So we're currently at this level where human intelligence is still higher. We're using image and speech recognition, and but AI is going to take up, and human intelligence will improve once we use more AI. And this is my final slide. So MAFLD is the new term, NAFLD is the old term, and the rates of cirrhosis, these are increasing. So EndoHepatology provides an additional tool to manage our patients with increasing fatty liver disease. EndoHepatology is the emerging field, and I talked about the diagnostics and therapeutics. It can be a one-stop shop where we can do several things during a single endoscopy. EBMT is reversible, and it has the potential to fill the therapeutic void. Some are already approved, and we have it at our division. DMR is the clinical trial we're looking forward. With new frontiers in liver biopsy, we now know that liver biopsy can be avoided in a majority of the patients, and we can use AI and liquid liver biopsy. So please stay tuned, but we are very excited to perform all of these and cater to our patients.
Okay, so we're going to have to cut you off right now, and I appreciate, but we are running a little behind time. I think if anybody has any questions, they can reach out to you, but I'd like to move on. Thank you. Dr. Flournoy?
All right, so Dr. Greidinger received his MD from the University of Michigan. where he also completed his residency in internal medicine prior to completing a fellowship in rheumatology at Johns Hopkins. He's been with the University of Miami and the Miami VA since 2004, served as the chief of the Division of Rheumatology from 2010 to 2020. He is currently the interim chief of rheumatology at the Miami VA. He has published myriad book chapters and articles in the areas of lupus, Sjogren's, and mixed connective tissue disease, and is primary investigator for multiple funded studies in rheumatology. He is section chief for mixed connective tissue disease for Up to Date, and is a reviewer for multiple journals, including the Journal of Rheumatology, Journal of Immunology, and Arthritis Research and Therapy. Please join me in welcoming Dr. Greidinger as he gives his talk titled Anti-RNP Autoimmunity.
Thank you very much, and appreciate the attention and attendance of all who are here. The work that I'm presenting includes some of our own research, which has been supported by NIH Merit Review, a variety of foundations, as well as a variety of pharmaceutical firms, as well as other research activities that I've done that have been supported by a variety of pharmaceutical firms, none of which should be relevant to the things that I discuss. This is the RNP antigen, the U1 small nuclear ribonucleoprotein. It is found in the nucleus of cells, of human cells, and really all eukaryotic cells, where it participates in removing introns from messenger RNA to get from pre-messenger RNA to mature messenger RNA, which it then participates in exporting from the nucleus. And it's composed of an RNA backbone with some double-stranded as well as single-stranded elements to it, and with several proteins that are hung on it, including the U170K, U1A, and U1C proteins, the U1D protein, as well as the B prime proteins, and the D and BB prime collectively are also the same thing as the SM or Smith autoantigen. The RNP collectively is a target of autoimmunity in lupus, where autoantibodies are seen in between a third and a half of patients, as well as in scleroderma, where about 15% of patients will have anti-RNP autoimmunity. And of course, it is the defining autoantigen in mixed connective tissue disease. So in order to have mixed connective tissue disease, by definition, you must have antibodies to RNP. So 100% of patients with mixed connective tissue disease will have, by definition, antibodies to RNP. Notably, the RNA backbone of this macromolecule makes a great agonist, since it can be recognized in its single-stranded parts by toll-like receptor 7 and in its double-stranded parts by toll-like receptor 3, among other danger signal sensors. And it turns out that the U1 RNA, the RNA backbone of the RNP autoantigen, is extremely common. This was a study published a couple of years ago out of McGill, where in an unbiased way, they looked in HUVEC cells for all of the RNAs that were present in intact cells or in apoptotic cells, and in particular focused on apoptotic blebs, or apoptotic exosomes, as they called them. And if you exclude ribosomal RNA, in all of these populations, the short non-coding RNAs were the most common, And among these RNAs, the most common of all of the RNAs was the U1 RNA. So the reason that RNP is a common target of autoimmunity includes the fact that the concentration of this is immense in dead cell debris. And it is, while not the absolute majority, it is the most common of the RNAs that are present in apoptotic debris, as well as in other dead cell debris. The yRNA is the series of RNAs associated with Rho, and a number of these others are familiar as well to rheumatologists. So since there are a number of different proteins that complex with RNAs and could be considered ribonucleoproteins, but they are not what we're talking about when we say anti-RNP antibodies. That's antibodies to the U1 small nuclear ribonucleoprotein spliceosomal antigen. What do we call the others? And from a rheumatology immunology standpoint, they're called RNA binding proteins, or RBPs. And there are lots of other autoantibodies that are against other RNA binding proteins, including Smith, which in addition to being part of the U1 RNP, can also be seen in several of the other U RNPs in the spliceosome. Ribosomal proteins, both of which are among the lupus-associated autoantigens. SSA and SSB, both bind the yRNAs and are typical Sjogren's autoantigens. RNA polymerase 3 and other RNA polymerases and the PMSCL exosomal proteins bind RNAs, and their autoantigens seen in scleroderma and scleroderma myositis overlap, and several of the myositis autoantigens as well. The tRNA synthetases, signal recognition particle, MDA5 also are proteins that are complex to RNAs, as are many other rheumatology autoantigens. The reason again being that it's a lot easier for a protein to be an autoantigen if it carries its own danger signal sensor, its own adjuvant along with it to stimulate an immune response. So we'll talk about a series of cases of anti-RNP autoimmunity and then have a little bit of discussion and gleanings based on these cases. So here, a 32-year-old woman with established anti-RNP autoimmunity under good clinical control on no medications delivered a baby boy at 35 weeks gestation. The baby developed diffuse erythematous photosensitive rashes over the next several days, but remained otherwise well. The rashes cleared in weeks. So what's going on here? Well, this is neonatal lupus, not the classic anti-Rho associated neonatal lupus with heart block and CHF, but the second most common form of neonatal lupus with cutaneous and sometimes hepatic manifestations due to anti-RNP antibodies being transferred from the maternal to the fetal circulation. And it turns out that if you expose skin to sunlight or UV light, then whether it's in a normal individual or a patient with lupus, you see a huge amount of dead cells that emerge. These brown nuclei are stained to recognize apoptotic cells from these skin biopsies, and there is an immense amount of apoptosis which is present with minimal sun exposure. This is what would lead to a minimal suntan or sunburn. 24 hours later, in a normal individual, almost all of the cells have been cleared out in a non-inflammatory way. But in patients with lupus, not only do they have impaired clearance of their dead cell debris, but they actually have even more apoptotic cells now because there has been an additional immune response based on the presence of the dead cell debris, bringing in autoantibodies and leading to activation of cytotoxic mechanisms, including complement-mediated mechanisms, to kill even more cells. So when we think in general about antigen-driven autoimmunity, we start often with dead cell debris, which can be recognized by B cells, presented by antigen-presenting cells to T cells, which then become activated and either directly or mediated through autoantibodies into tissue damage, which leads to more dead cell debris being produced and kind of a self-amplifying cycle. In neonatal lupus, you don't really have a lot of cellular immunity happening, but you have the passive transfer of the autoantibodies, which leads to more tissue damage and more production of apoptotic debris and the red inflammatory rashes. As the maternal antibodies clear, the disease goes away. So the gleanings from the existence of neonatal lupus as a manifestation of anti-RNP autoimmunity, it indicates that anti-RNP antibodies are directly pathogenic. If you have dead cells, anti-RNP antibodies plus dead cells have the potential to induce tissue injury without other significant immune mediators contributing. Next case. A 26-year-old woman was referred to the rheumatology clinic for assessment of photosensitive skin rashes, inflammatory polyarthritis, and pleuritic chest pains. Workup revealed anemia, leukopenia, proteinuria with red cell casts, high acute phase reactants, low complement C3 and C4, and high titer ANA, RNP, and Smith antibodies. So what's going on here? Well, you've got somebody who's got glomerulonephritis plus photosensitive skin, polyarthritis, ANA. This is lupus nephritis. And while we think in the setting of mixed connective tissue disease of anti-RNP antibodies as not associated with glomerulonephritis, in lupus patients, in studies that have been done, anti-RNP is a risk factor for the higher risk of presentation of glomerulonephritis in lupus patients. And this in part is due to the induction of type 1 interferons at a higher level. If you do multivariate analysis, it turns out that the RNP positivity tracks with the double-stranded DNA positivity as well in these individuals. So these are patients who have dead cell debris, which is not being cleared efficiently, and that are developing antibodies to multiple autoantigens. And in this full house picture, are developing more severe end organ manifestations of their lupus, including nephritis. And the mechanisms involved include starting with dead cell debris, which has modified self-antigen complexed with adjuvant, with these RNA molecules in this case. And that leads to both adaptive immune activation and recognition. B cells and T cells are activated, plus innate immune activation, including in dendritic cells, where the adjuvant can activate toll-like receptor 7 in the case of lupus. And these can combine to induce an augmented immune attack that diversifies it and leads to more cell death. We have looked in animal models at the relevance of the different danger signal sensor pathways. If you take regular black 6 mice and inject them once with the 70K RNP subunit complex to U1 RNA, the mice develop spreading autoimmunity to the U1 RNA, classic anti-RNP autoimmunity, and roughly half of the mice develop nephritis and roughly half develop lung disease. They're not completely separated. It's some have both. But if we try to do the same thing in mice that are either knocked out for toll-like receptor 7 or knocked out for toll-like receptor 3, something remarkable happens. In the TLR3 knockouts, there's still plenty of renal disease, but the rate of lung disease goes down dramatically. And conversely, in the toll-like receptor 7 knockouts, there's still plenty of lung disease, but there is a vanishing amount of renal disease. So said another way, toll-like receptor 7 mediated innate immune signals appear to be required for the development of nephritis in this anti-RNP autoimmune model, despite the fact that the autoimmunity persists in other locations. And this tracks with the fact that plasmacytoid dendritic cells, which are largely toll-like receptor 7 positive, traffic to the kidneys to mediate local autoimmunity, whereas in the lungs, the main dendritic cell subset that traffics there are myeloid dendritic cells, which are TLR3 positive and TLR7 negative. And we actually have confirmed this observation, at least in part, in a spontaneous lupus anti-RNP mouse, Trex1 deficient mice, which have lack of an endonuclease that digests RNAs and DNAs in the nucleus of cells. And these mice develop both anti-RNP antibodies and double-stranded DNA antibodies. And they get plenty of renal disease and a decent amount of lung disease. But even though they still have anti-RNP and double-stranded DNA antibodies in the Trex deficient mice that are TLR7 knockouts, they still get their lung disease, but they don't get any nephritis. So gleanings from considerations of lupus and lupus nephritis in anti-RNP autoimmunity. Firstly, when you see a full house collection of autoantibodies suggesting broad recognition of autoantigens in dead cell debris, be worried. These are lupus patients who are going to do badly, including having a high prevalence of nephritis. And secondly, TLR7 blockade is a promising treatment target. And actually at this past year's ACR meeting, National Rheumatology meeting, there are now small molecule TLR7 inhibitors that are in clinical trials that appear to be showing benefit, not in protection against lupus overall, but in protection against nephritis in humans. Stay tuned. Case 3. A 54-year-old woman, preschool teacher, was referred to the rheumatology clinic for joint pains with anti-nuclear antibodies and RNP antibodies present. The exam revealed osteoarthritis with no clinical features suggestive of an inflammatory rheumatic disease. The patient was followed for 12 months and discharged from the clinic. What's going on here? Well, it turns out that in addition to diseases that are associated with autoimmunity, including neonatal lupus, lupus, scleroderma, myositis, collectively mixed connective tissue disease, that the most common situation in which anti-RNP antibodies are observed is in people who do not have clinical autoimmunity. And among the most common reasons for this are the development of anti-RNP antibodies due to viral infection. In some cases, like in EBV and CMV infection, there are actually viral proteins that are molecular mimics of proteins that are part of the U1 small nuclear ribonucleoprotein that can directly mediate anti-RNP responses. And in a number of other cases, including parvovirus and COVID and others, the antiviral response involves inducing massive apoptosis of cells from the host. So you get lots of dead cell debris, which includes lots of U1 RNA and the emergence of autoantibodies against legitimate U1 small nuclear ribonucleoprotein that does not necessarily persist and progress to actual disease. In many people, unless they have an unfortunate environment or predisposing genetic factors, they'll have it for a little while and it'll go away. And although it's been difficult to estimate exactly the size of this group, there's consensus among the people in the anti-RNP world that this group appears to be much bigger than the autoimmunity group. And since anti-RNP antibodies cause tissue damage, as we saw from the neonatal lupus discussion, it's also been notable that there has been a tight association, which has been identified in long-term studies, between the emergence of anti-RNP antibodies and clinical disease. If you have anti-RNP antibodies which are going to cause disease or have caused disease, then the disease either emerges before the antibodies are noticed or within a year after the antibodies are noticed. And if more time goes by than that, then you are highly likely not to be in a situation where the antibodies are associated with disease, but associated with something else like a viral exposure. Other autoantibodies that have similar characteristics that mediate tissue injury and are closely, tightly linked to the emergence and expression of disease include double-stranded DNA antibodies, anti-cyclic citrullonated peptide antibodies, and anti-neutrophil cytoplasmic antibodies. Whereas lots of other antibodies are markers for rheumatic diseases, but they do not, in general, directly mediate tissue injury, and they are not tightly associated temporally with the emergence of disease. Anti-nuclear antibodies, antiphospholipid antibodies, rheumatoid factor being among these. So the gleanings from anti-RNP autoimmunity with no clinical disease is that 1 year after the discovery of anti-RNP positivity with no clinical disease means the person is safe. If they haven't gotten anything by 1 year, they're not going to. Case 4. A 42-year-old woman presented for assessment of cold-induced color changes of the digits, photosensitive skin rashes, inflammatory polyarthritis, and muscle weakness. Workup revealed Raynaud's phenomenon, sclerodactyly, elevated CK levels, low DLCO, and high titer RNP antibodies. So this is one of the criteria sets for mixed connective tissue disease, and yep. Checks off enough boxes. This is a patient with mixed connective tissue disease. Mixed connective tissue disease is a specific diagnosis. In order to say that you have mixed connective tissue disease, you have to have a clinical overlap syndrome, meaning features of multiple other classic inflammatory rheumatic diseases, lupus, scleroderma, myositis, rheumatoid arthritis, plus, in addition to being an overlap syndrome, you must have anti-RNP antibodies. So mixed connective tissue disease equals overlap syndrome plus anti-RNP antibodies. And it's distinguished from, for instance, undifferentiated or undefined connective tissue disease, which are patients who have some features that make us think that they might have an inflammatory rheumatic disease, but do not have enough features to meet the criteria for any given syndrome. Among patients who have mixed connective tissue disease, there is always a bit of a discussion as to whether they could or should be classified as lupus or not. In a study that we did here at University of Miami of about 100 patients with anti-RNP autoimmunity, there were some patients who were RNP positive who had lupus, there were some patients who were anti-RNP positive who had lupus and who met diagnostic criteria for mixed connective tissue disease as well as lupus diagnostic criteria, and some others who met MCTD classification criteria but did not meet lupus classification criteria. And it turns out that in a lot of ways, these groups were pretty similar. They had similar levels of disease activity, similar numbers of lupus criteria, a little less in the MCTD only group, and their rate of developing lung disease was quite similar. The message there being, if you have a lupus patient or a mixed connective tissue disease patient who is RNP positive, you should be doing lung disease screening of that individual over time. However, in other respects, there was a clear and intriguing difference, not only in the pure MCTD patients, but even in the lupus patients who also met MCTD criteria, the rate of nephritis was much lower in the lupus patients that met MCTD criteria compared to the RNP positive lupus patients who did not meet MCTD criteria. And likewise, the rate of Raynaud's phenomenon, even if you exclude that as one of the criteria to classify, is much higher in the MCTD positive individuals with RNP antibodies than in the lupus non-MCTD group. Mixed connective tissue disease occurs a little bit less commonly than scleroderma. Point prevalence about 4 cases per 100,000, incidence about 2 per million. It has rheumatoid arthritis-like, roughly 3-to-1 female to male prevalence. If you have major end organ disease, it's bad news. There's substantially more mortality in MCTD patients with cardiac disease or lung disease than in the groups that don't have it. And there does appear to be an important role of the adaptive immune system in these tissue manifestations, which is remarkably conserved from individual patient to other patient, and even between our animal models and humans, where the same epitope specificity at the B cell and T cell level is present, even the same V beta and V alpha chains are present across kidneys and lungs and circulation between human and mice. And if you do something to target these particular T cell receptors, that actually has therapeutic benefit. We've published doing that with a T cell vaccine, and it's intriguing to think that if it is affordable and safe to do, that CAR T cell treatments would be a potential additional option for this approach to management of these patients.
Dr. Greidinger, we're at the top of the hour. Yes, thank you. So,
thank you.
Thank you. If there are any questions.